Good morning, everyone. My topic is about proteomics for prediction of atrial fibrillation, a paper published in Heart. Uh, Thank you, Professor Dohami, for publishing it. The content include backgrounds, aims, methods, results, and conclusion. Atrial fibrillation is an irregular and often very rapid heart rhythm. During AF, the atrial beats chaotically and irregularly. Episodes of AF may come and go, or they may be persistent. Symptoms of AF may include irregular heartbeats, chest pain, extreme fatigue, dizziness or shortness of breath, heart palpitation, or even fainting. Why should we prioritize early prediction of AF? AF is the most common cardiac arrhythmia and a major cause of morbidity, mortality, and healthcare expenditure. AF can lead to blood clots. The condition can also increase the risk of stroke, heart failure, and other heart-related complications. Early detection of AF can lead to timely intervention and management, thereby improving patients' outcomes and quality of life. However, existing tools for AF risk stratification predict future events with limited accuracy and rely predominantly on traditional clinical risk factors, which cannot encompass the multitudes of pathophysiological processes contributing to the onset and progression of AF. Therefore, identification of novel biomarkers can advance our understanding of the mechanisms of AF and enhance opportunities for risk prediction. Proteins comprise structural components of tissues, organs, and whole organisms, and mediate most biochemical activities related to metabolism, regulation, signaling, growth, and senescence. Proteomic technologies can facilitate the early detection of diseases by identifying changes in protein expression levels or modifications before clinical symptoms appear. Proteomic profiling may aid in the discovery of novel biomarkers and that are upstream of the development of AF. In fact, previous studies have identified several plasma proteins associated with incident AF. However, although we speculate that a panel of multiple protein biomarkers that capture different pathophysiological pathways of AF may be more likely to reliably and accurately predict AF risk. The clinical utility of a combination of protein biomarkers for AF risk assessment has yet been demonstrated. As such, we aim to develop and validate a protein-based risk score for predicting incident AF and compare its predictive performance with traditional clinical risk factors and polygenic risk scores in a large cohort from the UK Biobank. Then is the methods. The UK Biobank study is a large prospective cohort study of over 500,000 individuals from 22 assessment centers across the UK, aged between 30 and 69 years at recruitment. Participants provided a wide range of information through baseline questionnaires, biological samples, and various physical assessments. Proteomic profiling on blood plasma samples were measured in the UKB Farmer Proteomic Project, UKB PPP, which included randomly selected subsets of 46,595 UKB participants at the baseline weight. The antibody-based all-link explorer 3072 PEA measured 2,941 proteins and captured 2,923 unique proteins. Proteins with more than 20% missingness were excluded in the predictor models, with the remaining 2,911 proteins or missing measurements mean imputed. Clinical refactors were selected based on HAMS2 AF risk model, which is comparable with the CHARGE2 AF risk model, but superior to the Framingham AF and atherosclerosis risk in community IRIC risk models. In the HAMS2 score, the H means hypertension, A was age, R raised BMI, M male sex, S sleep apnea, S smoking, AF alcohol. The weighted polygenic risk score was created for AF using 134 SNPs associated with AF at the genome-wide association significance in the meta-analysis of genome-wide association studies that did not include UKB participants. The study outcome was ascertained through data linkage with hospital admission data and DICE databases. The primary outcome was time to incident AF identified according to the codes of ICD 9th edition 4273 and ICD 10th edition I48 and OPCS version 4, K62.1 to K62.4. A study population were divided into training and testing sites in a proportion of 70% and 30% using a random sampling method stratified by outcome events. In training sites, Lyso-Cox regression models were used for training for age, sex, and protein levels using the R-package GoMites. Lyso penalty was used for model selection, and cross-validation were used to select penalization strands to determine the variables included in the model. In the testing site, the protein risk score was calculated as the linear part of the Cox model, including age and size, using the protein coefficients obtained from the training sites. Cox proportional hazard models were used to estimate the relationship of protein and polygenic risk score with outcomes. The prediction performance were evaluated using discrimination, measured by C-statistic and calibration curve. The reclassification performance were evaluated by the NRI and IDI. The net benefits were assessed through the decision curve analysis. Okay, then were the results. Due to the higher risk of AF in white individuals, this study were limited to white British ancestry to reduce confounding. Overall, this study included 36,129 individuals after excluding non-white British individuals, those with without genetic data, those with missing data on HAMS2 AF risk factors, and those with prevalent AF at baseline. Table 1 was the general characteristics of the study participants. All the participants included 41.8% were female with a mean age of 47.2 years. Participants had similar characteristics between the training and the testing sites. In the training site, Lyso analysis selected 47 proteins from 2,911 proteins with non-zero regression coefficients to create a protein risk score. Although NT-proBNP had the largest coefficient of coefficients of 0.427. During a mean follow-up of 11.8 years, 450 cases of incident AF were documented, with 1,715 and 535 cases in the training and testing site, respectively. We can see both the protein risk score, panel A, and the NT-proBNP were significantly and positively associated with incident AF. In the testing site, adding any one of the 47 proteins into the basic model, AD and sites, resulted in a C-statistic ranging from 0.733 to 0.785, with NT-proBNP having the highest C-statistic. As expected, the potency score had better predictive performance than any one individual protein, with a C-statistic of 0.802. The potency score and NT-proBNP had comparable predictive performance, both outperforming HAMS2 AF risk factor. With the C-statistic, we can see was 0.751, and polygenic risk score with a C-statistic of 0.748. Adding protein risk score and NT-proBNP into the basic model, including AD and sites, resulted in greater improvement in IDI than polygenic risk score or HAMS2 risk factors, with an IDI of 0.04T and 0.005 respectively. Moreover, adding polygenic risk score and or HAMS2 risk factor into AF protein risk score or NT-proBNP could not significantly improve the C-statistic. This result suggested that the selected 47 proteins have already encoded information conferred by genes, demographics, and these traditional risk factors. The protein risk score and NT-proBNP had comparable and higher specificity and sensitivity than HAMS2 risk factors and polygenic risk score. We can see the purple and the green curves. Both protein and polygenic risk score appear to be well calibrated. The protein risk score or NT-proBNP had greater net benefits than polygenic risk score or HAMS2 risk scores. You can see the yellow and the green curves, indicating that AF protein risk score or NT-proBNP could more accurately identify participants at high AF risk, with taking the trade-off with over triages into consideration. Furthermore, these intertwined curves showed that adding polygenic risk score and or HAMS2 AF risk factor into model with protein risk score or NT-proBNP could not result in significant improvement in the net benefits. Our study had several limitations. First, the current study used a testing site based on the same population from which the protein risk score was derived, which could lead to a lower estimation of prediction performance. Therefore, our findings need to be confirmed in more diverse and independent external cohorts. The participants in the current study were the white British, which limited the generalizability of our findings to other populations, as well as the comparison between ethnic groups. In conclusion, a protein-based risk score, particularly incorporating NT-proBNP, offers superior predictive value for AF risk over traditional clinical and polygenic risk scores, highlighting the potential for proteomic data in AF risk stratification. We also developed and validated a protein risk score, including 11 proteins, for predicting chronic kidney disease in patients with diabetes. Adding the CKD protein risk score into a validated clinical risk model, CKD-PC, could significantly improve the discrimination and reclassification of CKD risk. Moreover, we developed and validated a protein risk score of 31 proteins for predicting AD risk, Alzheimer's disease. The AD protein risk score alone constitutes a straightforward yet effective model for predicting AD risk with a C index of 0.867 in the testing site and 0.912 in the validation cohorts. Moreover, GFR, GFAP, and CGGA were identified as key proteins within the protein network. Okay, it's the end of my presentation. Thank you very much for your attention.